Thank you for joining us for Health Equity, Bias, and TBI Care. I'm Carrie Briner. I coordinate our Traumatic Brain Injury Center here at Hennepin, and this talk is being offered as part of, in recognition of Brain Injury Awareness Month, where we try to do different activities and events to bring awareness to acquired brain injury, specifically traumatic brain injury, and also highlight some of the talent we have here in many different areas of traumatic brain injury, including today's, which is a little different. But I think it's a really timely topic. I want to introduce Dr. Taylor Vang. She's a clinical psychologist by training and specializes in health psychology. She started her career in primary care behavioral health at Hennepin Healthcare and also worked in inpatient medicine units as part of the psychology consult service. Her passion with understanding how individual behavior contributes to systems inform her work in health equity and diversity, equity, and inclusion. Dr. Vang is currently the Director of Health Equity Education and Welcome Services at Hennepin Healthcare and has trained hundreds in the areas of health equity. So without further ado, I'll introduce Dr. Vang, and thank you so much for speaking with us today.
Thank you so much. All right. Well, I'm going to go ahead and get started. We're going to talk a little bit about health equity, bias, and TBI care, but we're going to actually kind of go backwards and start with TBI. And so let's see here. I'd like to share a story with you all to really get us started. And this is a story that is a personal story, but it really connects me to traumatic brain injury work. I'm a clinical psychologist by training, as Carrie mentioned, and with that, I've just always been fascinated with the brain, the human brain, the functionality of the brain, changes that occurs within the brain and how that can impact one's personality or mental abilities. But in 2019, I actually experienced ambiguous loss within my own family. It was July 4th, and my uncle, my dad's older brother, who has always been a pillar in our family, in our clan system, took a fall and suffered from a traumatic brain injury, which thankfully he survived. However, as you all know, changed quite dramatically, quite significantly, and to this day is not the same. So I think about that, and I think about the ambiguous loss that can come from that. I have the definition up here on the screen about what that ambiguous loss is, and really, having the physical person there, but the person not being the same. So I come to this topic of TBI, health equity, and bias from a personal perspective, though I will not be talking about bias or health disparities in the Asian American community, but more in alignment with what we're seeing in the data. By the end of this training, you should be able to identify disparities in TBI incidences in care, understand the process by which implicit bias is formed, explain how bias impacts health disparities, and then also apply evidence-based interventions to decreasing bias. I do have a disclaimer here. The disclaimer basically says it's important that we recognize all marginalized identities are subjected to health disparities on some level, but not limited to LGBTQ populations, ability status, migration, refugee status, or gender. A lot of what we're going to be talking about today, though, will be generalizable across the table beyond race, but I'm going to be focusing on race. I won't go into too much details. I'm just going to talk a little bit about TBI incidences. Research tells us that TBI-related deaths are most common in men and also most common in American Indians or Alaska Natives. I actually have this graph here that I pulled from the U.S. Department of Health and Human Services and the CDC. This was published in an article in 2019, but it tracked TBI related deaths from 2000 to 2017. And what you see here is that American Indians experience TBI deaths at a much higher rate than anybody else. Secondly, we have the white population, and then Black, Hispanic, and Asian Pacific Islander after that. When we look at this, and we look at TBI-related deaths, what the study did was actually broke it down into what were the mechanisms of injury. Oh, ask that everybody mute their mic.
We're supporting this program called that exposes high school students to healthcare careers.
All right, so sorry about that. So TBI, so mechanisms to injury. American Indian, Alaska Native, and whites, their TBI-related deaths were mostly due to suicide and unintentional motor vehicle crashes. For American Indians, Alaska Natives, they consistently had the highest rates of TBI-related deaths across. We saw that in the chart, right, in the graph. And the mechanisms to those injuries were related to unintentional motor vehicle crashes, right, which contributed to the highest number and accounted for the highest rates of the TBI-related deaths. Also, lower rates of seatbelt use, higher rates of alcohol-related motor vehicle crashes, and then deaths. But in the Black community, a lot of the TBI-related deaths were associated with homicides compared to other groups. I think it's important for us to understand this data because we know that in TBI, prevention is key. And so if we understand that suicide is one of the leading causes of TBI-related deaths, then it's important for us to strengthen access and delivery of suicide care. Also, then we can really hone in our efforts to teaching coping skills, problem-solving skills, especially to the populations that are most affected, American Indians, the white population. Or firearm injury, right, were the most significant mechanism to injury in TBI-related suicides. So taking a look at that. Reducing access to lethal means among persons at risk for suicide can prevent TBI-related deaths. Expansion of evidence-based strategies for reducing the likelihood of injury once in a motor vehicle crash, right? So I know that some places are looking at universal motorcycle helmet laws, right? This is where seatbelt laws and enforcing seatbelt laws and also booster seats can be really, really helpful as well. And then what we know about TBI-related deaths in the Black community being mostly homicide-related, we can start to really implement anti-violence interventions within those affected communities. So prevention is key. But what I'd like to ask you all, knowing what we just went through, knowing that the highest incidences of TBI-related deaths occur in Native American populations, what role do you think historical trauma plays? Minnesota is the land of the Dakotas and Anishinaabe. We are on Dakota and Anishinaabe land, and these peoples have had atrocious violence perpetrated against them for generations. Many of us have heard, especially recently, Native American boarding schools. This happened all over the country and even in Canada. Native American boarding schools were established in this country, in the US government, the late 19th century. Babies were taken from families, children taken from families, taken into boarding schools. And the intention behind this is to erase their culture. It was to erase their culture, to kill, annihilate, assimilate indigenous peoples. They could not speak their language at these schools. Many of these children were physically and sexually abused. And they didn't see their parents for months on end. I want us to think about the impact of that. because erasure of culture is a tool of colonizers. What happens when you lose your language, when you can no longer speak to your parents or your grandparents? What happens when you lose your culture, when you lose your roots? Just want to take some time to really take in these pictures. Some of you may be aware, I want to bring in some Minnesota history here, of the US-Dakota War. 1862, it should say of, not or, but of 1862. At about that time, treaties restricted the lands of the Dakota people in Minnesota so much that the Dakota people were left to live on land that could not sustain them. They were starving. Their living conditions were so poor that one day it was said that 4 young Dakota hunters killed 5 settlers. Tribe leaders in the Dakota tribe came together and a war was declared against the US government. The war lasted 37 days. After the war ended, over 2,000 Dakota men were taken into custody. Hundreds were in line to be executed. Ultimately, what happened was 38 men were executed. They were at Fort Snelling. They walked down to Mankato, and they were subjected to a public execution. This picture can be painful to look at. But I put the picture there because I want us to think a little bit about what we just talked about when it comes to disparities in traumatic brain injury related deaths in the Native American communities, suicide rates, and alcohol use rates. And I ask you all, I'd like to break you all out into perhaps just 2 breakout sessions, since we have about 6 people in here, not including myself. I want you to talk in your groups. How do you think historical trauma could be contributing to incidences of TBI related deaths? All right. And come back here to talking a little bit about TBI cares. I know that a couple of you alluded to the cares that you have seen yourself. I'm going to go to some of what the research is suggesting in terms of TBI cares, but I want to talk a little bit about how there are some of these discrepancies or disparities that are occurring in TBI related cares. The first one is a little odd. I really don't know what this implies or what this suggests or what it means, but it's interesting to take note of. So there was this research that looked at mild traumatic brain injuries in the emergency department and just disparities of care that people received based on race. And in this research, they found, after doing an analysis of the ED visits in the National Hospital Ambulatory Medical Care Survey, between this chunk of time, they found that Hispanics were 6 times more likely to receive a nasogastric tube, right, tube that sends food and medicine through the nose, as part of ED care for mild traumatic brain injuries. And the researchers really didn't understand why. They had guessed that it could be related to a potential language barrier, but we don't even know if there was a language barrier. The documentation of demographics just not that great in the medical record, but that was happening. Also, they found that Hispanics waited much longer to see a physician in the emergency department. Actually, many of the Hispanics left the emergency department before they were even seen by a physician because they waited so long. As it relates to mild traumatic brain injury in the emergency department, African Americans were more than 3 times likely to be seen by a resident rather than a physician compared to their white counterparts. African Americans were less likely to be returned to their primary care provider or referring physician after an ED visit for mild traumatic brain injury. What does that mean to be returned to your primary care provider? Oftentimes healthcare professionals, I'm sure you all know, will communicate with each other, right? And so if someone's seen the ED and they have their primary care provider at the CSC, the ED provider will oftentimes send a note, hey, the patient was seen, here's the things to follow up on, right? But that happened much less for African Americans that were seen in the ED. The authors said maybe it's related to this bias that Black patients are not going to show up for their follow-up care. This bias or this assumption, this false assumption that Black people aren't really adherent to medical advice. They're probably not going to follow up with their PCP. And so why go the extra effort in sending a note through Epic, right? For example. As it relates to traumatic brain injury, inpatient rehab discharge destinations, there's also some disparities there. So among young adults in general, even after inpatient rehab facility care, patients with TBI can struggle to return to pre-injury levels of functioning. This can affect their abilities to go to work, go to school, depending on how old they are, can impact their abilities in terms of whether they will ever be able to drive or their social life, right? And what that entails or what that implies. Also, there's an increased likelihood that younger adult patients will be dependent on family members if they have a severe enough traumatic brain injury. That is common for young adults in general. When we take a look at what the data suggests, race-based disparities among young adults, we find that up to 1 year after discharging home, Black and Hispanics, Latino patients with TBIs have worse physical, mental, and social outcomes than their white counterparts. And this was evidenced by their higher rates of readmissions, long-term disability, depression, substance abuse, and higher rates of unemployment. But more specifically, after transitioning home, Black and Hispanic patients with TBIs have 2 times higher odds of functional impairments, 2 times higher odds of depressive symptoms, 3.5 times higher rates of unemployment than whites up to 1 year post-discharge. It's pretty significant, which gets me thinking and wondering what is going on? What's kind of impacting that? Compared to whites, family caregivers of Black and Hispanic patients with TBIs report fewer post-discharge needs were met, reported more distress, and also needing more time for caregiving to their children at home. In a different article, researchers conducted a secondary analysis, right, to kind of figure out what's kind of going on with medical rehab, the data. Because again, when you look at this data, it's curious. What may be leading to higher rates of depression or lower functionality or higher need for family to step in and care? And what these researchers found was young adults of color were more likely to be discharged home rather than subacute rehab after inpatient rehab facility compared to white counterparts. And generally, this is a good thing, right? Generally, when you are discharged home, it means that you're doing well enough to go home and you don't need subacute rehab. But prior research shows that Hispanic Latino patients with TBIs are more likely to be discharged from inpatient rehab facilities with worse functioning outcomes compared to whites. So they're doing worse at the end of their inpatient rehab stay, but they're being discharged home rather than subacute rehab, right? This gets me curious, even more so, and it makes me wonder, what is leading to that? Why is it that Hispanic adults and perhaps even, or not adults, Hispanic youth and perhaps even Black youth are being discharged home and not being offered subacute rehab care at the same rates if they're doing pretty poorly. So we need to investigate this more. There's not a lot of data out there on health disparities, health outcomes with TBI cares, but this is definitely something that needs further investigation. Now, what we do know is when we look at the overall research with bias in medicine, is that providers that consider themselves altruistic, right, that are well-meaning, that embraces anti-racist ideologies, can still have biases that leads to health disparities. That there's evidence that health disparities are associated with the fact that people of color in this country receive unequal health care from well-meaning providers. Why might this be? Provider bias. So let's talk about provider bias. And to do that, let's talk a little bit about what bias is. So bias is the belief that there are some ideas, some people, practices that are better than others, and this typically leads to differential treatment. Now, there's explicit bias or bias that happens within our awareness, and so when we act on it, it's oftentimes with intention. But there's also implicit bias that occurs outside of our awareness unconsciously, and so when we act on it, sometimes or oftentimes it's without our intention. And it's actually implicit bias or bias that we are not aware that we have that can cause the most danger because we don't have the opportunity to say, oh, that bias does not align with my values. I'm not going to act on that. Let's talk a little bit about implicit bias. We know that well-meaning providers, again, who embraces anti-racist ideologies can still have bias in favor of white people over people of color. So if we all hold implicit biases, how then are implicit attitudes formed? To get at this, I want to talk a little bit about theory. I love theory. I'm not going to go into too much theory, but I think it's important for us to understand why this happens. Let's talk about the information processing theory. So the information processing theory states that our brains are like computers. Our brains have to be able to take in a lot of information, sift through that information, and organize that information, categorize that information into groupings that make sense. Groupings that share similarities. So things like skin pigmentation, age, these are primary categories that we see when we're meeting people for the first time. And so our brains group these things together. Over time, what happens is that when we group things together, it makes it much easier for us to retrieve the information when we need it, right? It helps us navigate the world in effective ways. If our brains didn't develop schemas, every single encounter would be like starting over, which would require a significant amount of energy and time. So, for example, when I first learned how to drive my parents' Toyota Camry, I was extra attentive to my mirrors, making sure that I was signaling every time I turned, the pressure of my foot on the brakes, right, and acceleration. I was really mindful of that. And so going to a destination and back sometimes honestly felt exhausting because of the mental effort it took. Over time, my brain continued to learn how to do this, categorize these movements together, categorize and build these things together. So now I have a schema for driving automobiles. And what has also happened is now I'm so used to it, I can go from one destination to the next without even thinking about it. Sometimes I get home, I don't even know how I ended up home. And now I can actually jump into a sedan, a truck, an SUV, a van, even a motorbike, and have the general idea of how to operate this automobile. How our brains work, right? To make it easier for us to navigate the world. And so our brains do this. And eventually we create a bunch of filing cabinets filled with information, categorized in ways that we think have things in common. But in other words, really, we form neural pathways. When we encounter new situations and or need to draw from past experiences, our brains go right into the filing cabinets, kind of look into the files. Oh, this is the one that I think will be useful in this situation. So that's how our brains work, right? We have these groupings. But let's talk a little bit about the history behind the content, right? The bias content, right? And that is the context behind it. We're going to take a deeper dive. We're going to talk about the history of racism. But I want to start with the difficult history between our academic institutions and African American history. For the purposes of this training here, I'm just going to focus in on African American history right now. Our top tier universities, our Ivy League schools like Harvard, Princeton, Yale, Columbia, these are universities that have put out incredible scholars that have changed and shaped fields of science, medicine, art, and technology. These are the same universities that also produce scholars who published in peer-reviewed journals on the superiority of the white race and inferiority of Black and brown races. These scholars claimed that Black people were closer related to other species than the human species. And I want you to think a little bit about what is the impact of that when you have these revered scholars from these top tier universities writing in scientific journals about this. What is the impact of that? And how might that impact continue to haunt us as a society even today? To do that, to demonstrate that, I want to talk a little bit about what happened about 24 years ago, 1998. There was a researcher by the name of Dr. Wakefield. He and his colleagues put together a research article, published it in the Lancet, a pretty highly revered scientific journal. And the article was about how autism was caused by the MMR vaccine. This article was out there from 1998 until 2010. In 2010, there was enough research, secondary, third, other researchers that went in and studied this and said, we found no proof of this. And so not only is it not a causal relationship, but there's not even really a correlation here. And so in 2010, that article was retracted based on the incorrect conclusions. But the damage had already been done. By the time the article was retracted from the shelves, right, it was estimated that about tens of thousands of people globally, not just in the US, globally had refused the vaccine, leading into an uptick of measles and other diseases that were controlled for. Actually, even now, there are vulnerable communities that still hold the claims of that article to be truth and still refuses to vaccinate their children. And these communities are still suffering those consequences. That was one article 2 decades ago. And we're still feeling the impact of that. Let's go back to academic institutions and the African American population. What are the insidious ways that the narratives on the Black race continues to make its way, seep into our legislation, right? Our legislation, our education systems, our financial institutions, our medical institutions. It still shows up. Prior to the 1920s, North American and European social scientists nearly all agreed that whites were superior to people of color, but specifically in the areas of morality, mental abilities, and physiology. Black and brown people, less morals. Black and brown people, not as intelligent. Black and brown bodies built for more laborious work. Black and brown bodies, especially, have their nerve endings are not as close to their skin, so they have a higher tolerance of pain. These are narratives that are out there. And this school of thought led to the eugenics movement. The movement to improve the human race by encouraging the reproduction of those with good genes, desirable traits, and stopping the reproduction of those with so-called less desirable genes. Who are the ones with desirable genes? People who were white, able-bodied, Christian, heterosexual, right? Did not have a severe mental illness. Everybody else, led to genocide, led to mass sterilization campaigns that sterilized entire populations. Some pretty horrible outcomes came from this. I want to pivot a little bit and talk a little bit now about other things that impact the context the content of our bias, and that is the media. So our decisions on what to read or watch can influence the content of our stereotypes, right? Let's take a look at this real quick. This is a visual that I want you to look at. And in this visual, we have two boys taking a bath. We have a white boy and a black boy, two scenes. Scene 2, the black boy is done taking a bath. And look at the soap. The soap is so good. The soap is so effective, it washed the black off of the boy's body. What is the messaging here from 1765? The messaging is black is bad, black is dirty. Look, our soap is so good, it washes the black off of you. I ask though, was it, a sign of the times in a way? Here's an advertisement by Dove Soap in 2017. This advertisement was all throughout Facebook. I believe there were billboards as well. And this is a part of that advertisement where you see it starts with a black woman who uses the soap and the soap turns her white. What messaging do you think this communicates through the history, knowing the history that we just went through, right? Or this one, where you have a before and after, and you have a darker skinned woman, and then a brown woman, and then a white woman, right? And the darker, the drier, and then after. Or from this bottle here that says nourishing lotion for normal to dark skin. Normal to dark skin. What abnormality do you think is being implied here? Some of you might be thinking, what in the world? How in the world did these atrocious ads pass through all of the lines of approvals, right? That must be there. How did it get published? How did it get put on bottles? And some of you may be thinking, they didn't mean any harm. Sometimes darker skin can be drier. And really, Dove is just really trying to represent all women. What I'll say is bias, implicit bias, especially when we're not aware of it, can cause harm. Unintended, maybe, but harmful nonetheless. You don't have to be malicious in intent to really still act on bias and lack consideration and produce negative outcomes. Again, going back to how the harm of implicit bias, when we're not aware of it, can actually be greater. Now, I want to talk a little bit about what makes a good clinician, right? Because we are participants in a healthcare system. What makes a good clinician? A good clinician is somebody who can take in a whole bunch of information, categorize the information so that later, when they need to retrieve that information, especially in urgent, high-pressured situations, they can. And they can sift through that, and they can actually generate a hypothesis of what is going on for this person in front of them, reach a probable diagnosis, and have a treatment plan in mind. Good clinicians are trained to do this. They go to school, years of school, and then clinicals, and then internship or residencies, just to master their art. Good clinicians can do this. And what's just uncanny is the parallel of what it takes to be a good clinician, the process that it takes, and also the process that primes our bias. That's the information processing theory that we went over earlier. If the processes overlap so much, then what am I asking from clinicians? Well, one of the things I'm asking from clinicians is when you're engaging in your work and you're doing the things that you're doing that you do best, to pause and ask yourself if there are assumptions that are being made about the diagnosis or what may be the etiology of the diagnosis or even treatment planning. And if you are operating off of assumptions, then clarifying that with your patient, right? Instead of going off of your assumptions. Again, researchers found that providers bring their negative preconceived beliefs about Black and Brown intelligence, disposition to engaging in risky behaviors, likelihood of medical cooperativeness or adherence, and it influences their treatment recommendation. In other words, providers make assumptions on whether or not their patients can understand the differences between recommendations or treatment interventions or preventions. They make assumptions on whether or not this patient is going to be continuously engaging in risky behaviors without checking with the patient, or the likelihood that this patient is going to follow up. Again, remember that study that said that for Black patients in the ED with mild traumatic brain injury, there isn't that circling back to their provider based on that assumption that the patient's not going to go anyways. And how is it that all of these assumptions that we make in healthcare, how might it influence outcomes for the patient if we don't check the assumptions that we're making? And how does that contribute to health disparities? I think it's always important for us to take a look at social determinants of health when we're talking about inequities or health equity. But I think it's especially important that we think about our role in healthcare, because we play a role in this system. So I'd like to break you all out into small groups again and have you talk about what you think your role is in addressing health equity, bias, and TBI prevention or care. Okay, for the sake of time, we're not going to have time to go over some of the discussions that you all have engaged in briefly there, and I apologize about that. But I do want to make sure that we have some time to talk about what we can do. What can we do? Because we went over a lot today. We talked about incidence rates, we talked about TBI-related deaths, we talked about disparities when we look at who's dying from traumatic brain injuries. And looking at that data and understanding some of the reasons behind that, right? So MVCs, motor vehicular crashes, or alcohol use or suicide, then we can really start to hone in on our interventions. And then we also saw that even in the cares after TBI in the ED, and then also rehab cares, there's also disparities there as well. And we went into bias, but now if we think about bias, right? What can we do? Tackling our bias is a very personal journey. And so one of the things that I will say is, as I go over the empirically supported interventions and decreasing your own implicit bias, it's important for you to assess for yourself, where are you, right? And who do you see yourself as, right? In terms of your values. And are you close to that? How much more growth do you need individually to get you to where you want to be as a person? Because this is very personal, it's going to really depend on where you want to see yourself, the movement that you want to see in yourself, in your life, and as you as a person, because it takes a lot of work, right? When we're talking about decreasing bias, especially implicit bias, and it takes intentionality. Talk a little bit more about that. So one of the things that we can do is acknowledge that our brains are primed for bias just because of how our brains function. There is a very good reason for our brains to function this way, again, so that we don't have to start over every single time we engage in a situation that is not novel, that is not new. Our brains work in this way. And so instead of fighting to say, I don't have a bias, focusing on how are ways in which I am biased, so that we can continue to bring the unconscious bias into our conscious awareness. Once we do that, once we acknowledge that we all have biases, we can start to decrease that bias by perhaps increasing our intergroup contact. So this is directly making sure that we are expanding our in-group or our friends, that we are building meaningful relationships, longer term relationships with people who don't look like us, don't talk like us, who don't have the same beliefs as us, perhaps people who have a different sexual orientation or gender identity or religion or race or ethnicity. And the more we can build long lasting, meaningful relationships, the more these people become a part of our in-group. because there tends to be in-group favoritism here, right? We like people who are like us. We think of ourselves as good people. So if they're like us, they must be good too. So expanding our friend group can be helpful. A little less helpful than intergroup contact is indirect contact. This is things like book clubs, watching movies, or watching shows that really does a really good job of telling the stories that have not been told before. Making sure, of course, that the material, the content is being written from those that are from that community that we're trying to learn more about. The last one that I will bring up is habit extinction. And this is one of my favorites. I know it's 1 o'clock, I apologize, but habit extinction is getting at behavior change. If you enact in a behavior that doesn't align with your values, you can change that behavior by replacing that behavior with something that you would prefer. For example, as a psychologist in inpatient units, sometimes I'm in a patient's room that needs an interpreter, and another provider will walk in, see that I'm a brown employee, and have said to me, "Oh, hey, you're the interpreter I've been waiting for." And in situations like that, I'll let them know, actually, no, my name is Dr. Bang. I'm the psychologist who consulted. And sometimes they feel horrified in their response, but that's a perfect situation where instead of shying away from the mistakes that we all make these mistakes, instead of shying away from it, actually saying, you know what, that's a behavior I want to change. Next time I walk into a room and I see an employee of color and I'm waiting for an interpreter, I'm not going to jump to making that assumption. I'm going to actually introduce myself, ask them to introduce themselves, replacing that behavior so that it becomes a positive habit instead of one where it gives way to implicit bias. Thank you all so much for your time.
Thank you so much, Dr. Vang.
Thank you.
Really appreciate it.
Yes, you're welcome. I hope you all have a great day.
Thank you. You too.
Take care.
Bye.